What if I told you there is a medication that not only helps people lose weight, but actually prevents heart attacks and stroke? Not just reduce risk a little, we are talking 26% fewer heart attacks, 39% fewer strokes. Sounds like a miracle drug, right? Well, it's real. It's called GL1 Receptor Agonists. When these drugs first come out, they were marketed as weight loss medications, but here's what most people don't know. The cardiovascular benefits are even more impressive than the weight loss. In this video, I'm Dr. Fernandez and I'm going to walk you through the science, the evidence, and real clinical cases so you understand exactly how these medications work and when to use them. By the end, you'll know more about GLP-1 inhibitor than most doctors. Let's dive in. Here's what you're going to walk away with today. First, you understand the mechanism, not oversimplified explanations, but the deep pharmacology that explains why this drug does do so many things. Second, you know the cardiovascular evidence called Sustain 6, Leader, Rewind, and what they mean for patient care. Third, you'll confidently determine whether a GLP-1 is right for a specific patient. Not everyone should be on one, despite the hype. Fourth, you understand the safety profile, which side effects matter, how do you manage them, how do you talk to patients so they don't quit after the first week. Fifth, you'll understand cost and access issue. $1,200 a month is a barrier for many people. Finally, you'll see that this field is evolving rapidly. New drugs coming, new indications, new trial data. You'll be equipped to stay ahead. Let me start with something your body does naturally every day. When you eat a meal, your intestines release a hormone called GLP-1, glucagon-like peptide 1. GLP-1 circulates in your blood, but it only lasts about 2 minutes before an enzyme called DPP4 breaks it down. It's like a text message: send, read, and delete it. Your body makes a fresh batch with every meal. Here's the revolutionary insight. What if you could give someone synthetic GLP-1 that resists DPP4 breakdown? What if you could make it last hours instead of minutes? Boom. That's exactly what GLP-1 agonists do. And this is key. GLP-1 receptors aren't just on your pancreas. They're all over your body. On pancreatic cells where it triggers insulin. On nerve cells in your brain where it kills appetite, on your heart where it improves function, on your kidneys where it increases sodium loss, on your blood vessels where it improves function. This distributed system explains why a single drug has so many effects. You're not adding a new chemical, you're amplifying something your body already does, but smarter and longer lasting. Mechanism. When a GLP-1 drug enters the bloodstream, it does two distinct things. Level 1, the diabetes stuff. In the pancreas, GLP-1 tells the beta cell, which are the release insulin. But here's the key word: only when blood sugar is high. If glucose is dependent, this means GLP-1 drugs are extremely safe for hypoglycemia. The drugs also tells alpha cells, stop, release glucagon. Glucagon raises blood sugar, so you're hitting it from both sides. More insulin when you need it, less glucagon when you don't. Level 2, the cardiovascular magic. Beyond the pancreas, these drugs work in the brain, rewiring hunger, the kidneys increasing sodium loss, lowering blood pressure, the heart improving function, and the blood vessels better function. When you lose weight, 8 to 22% of body weight, the heart workload drops. The heart doesn't pump as much. Blood pressure improves. Atrial fibrillation risk drops. Diastolic dysfunction improves. So cardiovascular benefits come from multiple mechanisms: weight loss, direct cardiac effect, blood pressure reduction, improved metabolism. That is why it's so effective. Medications. Right now, we have 3 main camps of GLP-1 drugs, plus more coming. Semaglutide, Ozempic for diabetes, Wegovy for weight loss by Novo Nordisk, once a week injection. the heavyweight champion. Why? Most clinical trials data, most MACE reduction, 26% in SUSTAIN 6, most real-world experience. Trulicity, also once a week from Eli Lilly, solid MACE reduction, 12% in REWIND. Victoza and Saxenda from Novo Nordisk, daily injection. Leader trial showed 13% MACE reduction and notably 22% reduction in cardiovascular death. Tirzepatide or Mounjaro, Zepbound, by Eli Lilly, not just GLP-1, it's a GLP-1 plus GIP. Better weight loss, 20 to 22% instead of 15 to 18% once weekly. Still waiting for cardiovascular outcome trial data. Coming soon. Retatrutide, triple agonist, oral formulations, longer acting versions, monthly, quarterly dosing. Key point: you have options. If one doesn't work, there are alternatives to try. The evidence. In 2008, the FDA said every new diabetic drug must prove it doesn't increase cardiovascular events. This leads to a large long-term clinical trials called CVOTS, cardiovascular outcome trial. These are the gold standard. Thousands of patients often follow 3+ years with hard endpoints, heart attack, stroke, death. For GLP-1, results are consistently positive. We are not just seeing safety, we are seeing benefit. ELISA, neutral, didn't hurt, didn't significantly help. Leader, liraglutide, 13% reduction in major adverse cardiovascular events with a 22% reduction in cardiovascular death. SUSTAIN 6, semaglutide, 26% reduction in MACE, biggest reduction we have seen. REWIND, dulaglutide, 12% reduction in MACE. Think about that. In a heart disease patient on a GLP-1, there's roughly a 1 in 4 to 1 in 3 chance of preventing a cardiovascular event over 2 to 4 years. That's huge. That's the benefit we see with high-intensity statin in acute coronary syndrome. This is why we now recommend GLP-1 for secondary prevention, patients who already had a heart attack or a stroke. SUSTAIN 6 is the landmark trial, published in New England Journal of Medicine in 2016, still the gold standard evidence for semaglutide cardiovascular benefit. They set up around 3297 patients with type 2 diabetes who either had cardiovascular disease, heart attack, stroke, or documented coronary disease or were at high risk. They randomized half to semaglutide 1 milligram once a week, half to placebo. Everyone got standard care, follow up to 2.4 years. The results that matter: semaglutide reduced MACE by 26%, hazard ratio 0.74. That's a real reduction. Treat 20 patients for 2.5 years, prevent one major cardiovascular event. Breaking it down, 31% fewer non-fatal heart attacks, 39% fewer non-fatal strokes, 15% fewer cardiovascular death. Didn't quite reach statistical significance. One thing that made cardiologists pause: heart failure hospitalization appeared to increase slightly with semaglutide, though not statistically significant. Weight loss, 2.3 kilograms net compared to placebo. Why this trial changed everything? Before SUSTAIN 6, we had some evidence GLP-1 were safe. SUSTAIN 6 showed that they were actually prevent disease. That elevated GLP-1s from nice to have to should consider nearly every heart disease patient. The leader trial is equally important but tells a different story. Bigger population study, 9,340, and a follow longer, 3.8 years, published in 16. Key difference: SUSTAIN included both established cardiovascular disease and high risk. Leader was purely secondary prevention. Everyone had already had a heart attack, stroke, or unstable angina. Medication: liraglutide, 1.8 milligrams daily, not weekly, like semaglutide. Results: primary MACE showed 13% reduction, smaller than SUSTAIN 6, 26%, but still solid. But cardiovascular death decreased by 22%. That's the hardest outcome, not didn't have a heart attack but didn't die. That's powerful. Heart failure hospitalization, 19% reduction. This is opposite to sustained 6, slightly increase. Liraglutide actually protected against heart failure hospitalization. Takeaway, both trials showed cardiovascular benefit, but with different emphasis. Sustained 6 show stroke and heart attack prevention. Leader show cardiovascular death reduction and heart failure hospitalization reduction. For practicing cardiologists, these data support GLP-1 use in secondary prevention. Both drugs have proven benefits. Metabolic benefits. Here's something interesting. The cardiovascular benefit might not be primarily about blood sugar control. In trials, hemoglobin A1C reduction was modest, usually 1 to 1.5% points. Yet, cardiovascular benefit was substantial, 26% MACE reduction. So something else is going on beyond glucose control. Blood pressure. GLP-1s lower systolic blood pressure by 2 to 5 milliliters of mercury. Sounds small? Epidemiological, 5 millimeters of mercury reduction means roughly 10% fewer strokes and 7% fewer coronary events. Lipid, HDL increased 3 to 6%, LDL decreased slightly, triglyceride decreased 10 to 20%. Pretty significant. Inflammation. High sensitivity CRP decreased. Less inflammation means more stable plaques, less rupture risk. Endothelial function. Blood vessel lining works better. Better vasodilatation. Better flow. Less thrombosis. Atherosclerotic plaque. GLP might stabilize plaque, making rupture less likely. This drug works on every physiological system involved in cardiovascular disease. Weight loss, blood pressure, lipid inflammation, endothelial function, plaque stability. That's why benefit is so robust. Multiple mechanisms working together, hallmark of truly effective drugs. Heart failure is complicated, and I want to be honest about what we know and don't know. Heart failure with reduced EF. We don't have a dedicated large trial in heart failure with reduced EF combined sustained and leader data show slightly increasing heart failure hospitalization with semaglutide but slightly decreased with liraglutide. Not reassuring. Why might heart failure reduced EF be a problem? GLP cause natriuresis, sodium and water loss. In a patient already volume depleted, this could precipitate acute kidney injury or worsen heart failure. Don't initiate GLP-1 in heart failure with reduced EF. Wait for dedicated trial data. If already on and doing well, don't necessarily stop it, but monitor carefully. Heart failure with preserved EF. Completely different study. Links to obesity and metabolic disease. Single most effective intervention in weight loss. STEP heart failure trial 23 looked at semaglutide in heart failure with preserved EF with obesity. Result 21% reduction in cardiovascular death of heart failure hospitalization. The mechanism, weight loss. My recommendation is heart failure with preserved EF with obesity plus GLP-1 is a strong consideration. When you hear heart failure, immediately ask reduce or preserve. That determines whether GLP-1 is contraindicated or indicated. Weight loss mechanism. Weight loss is probably the biggest driver of cardiovascular benefits. GLP-1 causes 8 to 22% reduction in weight. At 220 pounds, that's 18 to 48 pounds. Life-changing. What weight loss does to the heart. Workload drops. Heart doesn't work as hard. Myocardial oxygen demand drops. Efficiency improve. Structural remodeling. Obesity causes left ventricular hypertrophy and stiffness. With weight loss, hypertrophy regress. Wall stress decreases. Diastolic function improves. Arrhythmia reduction. Obesity causes atrial fibrillation with 5 to 10% weight loss. AFib burden drops 30 to 40% with 15 to 20% weight loss from GLP-1. AFib risk drops dramatically. Metabolic. Insulin sensitivity improves. Obesity drives insulin resistance, which drives atherosclerosis and inflammation. Break obesity, break the cascade. Direct cardiac effect. GLP receptors are directed on heart cells. Activation improves contractility, reduces cell death, might reduce fibrosis. Clinical reality. Weight loss is powerful, but it's not just passive. Less weight equals less work. There's active pharmacology. That's why GLP-1 are so effective. Patient selection. Not everyone should be on GLP-1 despite the hype. A strong indication, type 2 diabetes plus established cardiovascular disease, prior MI, stroke, coronary disease. This is the easiest call. Prior cardiac event, GLP-1 is indicated. Type 2 diabetes plus heart failure persevere with obesity. Weight loss is the therapy. Type 2 diabetes plus obesity. BMI more than 30. Drugs were approved for this. Relative indication, multiple cardiovascular risk factors even without prior event. High risk profile, type 2 diabetes plus uncontrolled blood pressure. Caution, recent acute coronary sin, less than 3 months. Acute decompensated heart failure. Advanced CKD, absolute contraindication. Personal family history of medullary thyroid cancer. Mentus syndrome, pregnancy, type 1 diabetes. Severe GI disorders. Bottom line, does the patient have cardiovascular disease or obesity? Do they have type 2 diabetes? Contraindications? If yes, yes. No, if you got a candidate. Side effects. Let's talk about what actually happens, honestly. This is where people bail out. Common GI stuff. Nausea in 20 to 45% of people, usually resolve in 2 to 4 weeks as body adapts. Think of it as adjusting to altitude. Initially you feel off, body acclimates. Vomiting 5 to 10%, usually when nausea is severe. Diarrhea 10 to 20%, often mild. Constipation, some get it, others diarrhea. How to minimize? Tragedy 1, slow titration. Start at 0.25 for 4 weeks, then 0.5 milligrams, then 1 milligram. Strategy 2, dietary tweaks. Smaller meals, low fat diet, avoid greasy food, stay hydrated. Strategy 3, timing matters. Inject same day time each week. Strategy 4, normalize it. Tell patients upfront. Most people experience some nausea. It's temporary. Serious adverse events are rare. Pancreatitis 0.1% to 0.2%. Cholecystitis and gallstone 3 to 4%. Retinopathy worsening, more concerning type 1 diabetics. Allergic reaction are rare. Thyroid tumors seen in rodents, 0 cases in humans, but a boy in medullary thyroid cancer history. Diabetic ketoacidosis, very rare with appropriate selection. The reassurance, these drugs are well tolerated. Most side effects are minor and go away. Serious events are generally rare, not a dangerous medication, a safe, effective medication with manageable side effects. Dehydration risk. Here's a side effect that isn't famous but matters in specific patient. Dehydration. GLP-1 causes volume loss through multiple mechanisms. Natriuresis, kidney loses sodium water. Reduce intake, people eat less. Osmotic diarrhea, alter glucose handling. Who's at risk? Type 2 diabetics plus chronic kidney disease. GFR less than 30. Kidneys are already struggling. Type 2 diabetic plus SGLT2 inhibitors plus GLT1 additive natriuretic effect. A type 2 diabetic plus loop diuretic. Hot climate or heavy exercise. What happens if dehydrated? Creatine rises. Acute kidney injury risk. In baseline CKD, you could go from GFR 35 to 20 quickly. Electrolytes and dermatitis, dizziness, thrombosis risk. What to do? Concept of repression. Drink 2 to 3 liters of water daily. Morning hot weather. Check kidney function and electrolytes at baseline. Check again at 6 to 8 weeks. In advanced CKD, you might avoid GLP-1 entirely. Real case, 72-year-old with a GFR 28 starting on semaglutide. Developed diarrhea, reduced intake, was a loop diuretic. Within 8 weeks, creatine went from 2.2 to 3.1. Acute kidney injury. This is preventable with counseling and monitoring. Drug interaction. GLP affect how the drugs are absorbed. Delay gastric empty. Main issue. Oral medications absorb slower. For most drugs, doesn't matter. Still absorb just 30 minutes later. Nitroglycerin. Time sensitive. Patients need fast relief for chest pain. Delay absorption could matter. Oral contraceptive. Reduced absorption could affect efficacy. Glucose lowering meds critical. If patients are already on insulin or sulfonylureas, adding GLP lowers blood sugar further. Hypoglycemia risk. Solution. Reduce insulin sulfonylurea doses. Monitor glucose closely. Metformin. No interaction. Safe to combine. SGLT2 inhibitors, no direct interaction but both increase natriuresis. Combined diuretic fat is additive. Monitor hydration and kidney function. Warfarin absorption might increase, raising INR. Monitor INR more frequently. Levothyroxine absorption might increase. Monitor TSH, baseline assessment, review all medication, get A1C, glucose, renal function, electrolyte, lipids, weight, blood pressure. Screen for contraindications, ongoing monitor at 3 months, weight, blood pressure, glucose tolerance at 6 to 12 months, A1C, lipids, renal function. Prescribing patients education first. We are studying a medication that lowers blood sugar at typically cause weight loss. You probably lose 5 to 10 pounds initially, more over time. Most people feel nauseous for 1 to 4 weeks, but it passes. We'll start at the lowest dose and go slowly. Discuss costs, $900 to $1,400 a month without insurance. Are you insured? Can you afford this? Semaglutide dosing, week 1 to 4, 0.25. Subcutaneous weekly, week 5 to 8, 0.5 weekly, week 9 and plus 1 milligrams weekly. Tirzepatide dosing, week 1 to 4, 2.5 milligrams weekly, week 5 to 8, 5 milligrams weekly, week 9 plus 10 milligrams weekly. Teach injection technique, fresh needles every time, rotate site, thigh, belly, arm, managing side effects, severe nausea, don't escalate, stay at dose longer, diarrhea, dietary changes, ensure hydration. Treatment duration, indefinitely probably. There are weight loss and cardiovascular protective drugs. Stop them, weight returns and benefits wear off. Monitoring, phone call at 2 weeks, in person 6 to 8 weeks, check weight should be down. Blood pressure, glucose, GI symptoms, labs if needed, follow up in 3 months, annual repeat labs. Key principle, start low, go slow, and individualize. Let's be real, these drugs are expensive, $900 to $1,400 monthly without insurance, $10,000 to $16,000 yearly. Insurance improved but inconsistent. Medicare recently approved coverage for semaglutide, Ozempic, for glucose control, used because Medicare covers 45 million of people in the US, but coverage for weight loss is still limited. This creates a fairness problem. Wealthy patients access life-changing prevention. Less affluent patients can't. How to help ask about insurance. Does patient have it? What's copay, deductible, manufacturer assistance program? Novo Nordisk and Eli Lilly both have free medication programs for uninsured and uninsured. Many qualify. GoodRx and pharmacy discounts sometimes beat insurers. Discuss with insurance company about prior authorization. State pharmaceutical assistance program. The future, semaglutide generic expected in 26 to 27. Generic drugs cost 80 to 90% less. International competition and biosimilars will drive global prices down. Right now, cost is access issue. In 2 to 3 years, much more manageable. Advocacy, talk to patient about cost, help them navigate assistance program. If passionate, advocate for policy changes, expanding access. Cardiovascular medicine should be available for everyone. Future direction, the field moves fast. Watch for this development. Heart failure trial, STEP, heart failure persevere shows semaglutide benefit heart failure persevere. Changing heart failure persevere management. Award heart failure for dulaglutide in heart failure not yet published. Leader renal for liraglutide in CKD. New drugs, retatrutide, triple agonist, GLP-1 plus GIP plus glucagon. Phase 3 show 24 to 25 weight loss. If cardiovascular outcomes favorable, next generation standard. Oral formulation developing, monthly, quarterly injection instead of weekly. Expanding indications, non-diabetic obesity with cardiovascular disease, atrial fibrillation, burden drops with weight loss, CKD with diabetes, neurological applications, preclinical, Alzheimer's data. The momentum when drug class show broad benefit, research community gets excited, money flows, trial launch. Within 3 to 5 years, landscape will look different. Case 1, post-MI, 58-year-old man, MI 6 months ago on ACE inhibitor, beta blocker, statin, and aspirin still at risk. Another minor stroke, possibly. Metabolic profile, A1C over 8.2, BMI at 34. Blood pressure 138 over 86, lipids LDL 68, HDL 38, triglyceride 210. What else can I do to prevent another heart attack? Clinical reasoning, textbook case for GLP-1. Why established cardiovascular disease prior MI, type 2 diabetic, sustain and leader. A specific study, patients like him showed 13 to 26% MACE reduction plus obese and metabolic dysfunction. GLP addresses all. Proven MACE reduction. Weight loss 8 to 15%. 18 to 26 pounds, blood pressure reduction, 2 to 5 millimeters of mercury, HDL increase, triglyceride reduction, improving insulin sensitivity. Prescription, I want to start you on semaglutide, weekly injection. Proven or reduce heart attack or stroke risk by 26%, usually cause weight loss, helps blood sugar. Most people feel nauseous for a few weeks, goes away. Expectation, A1C drops 8.2 to 7, weight loss 15 to 20 pounds, blood pressure 2 to 3. Cardiovascular event risk drops 26. How do you not offer this to a post-MI patient with metabolic disease? Evidence too strong. Heart failure with preserved EF. 65-year-old woman with heart failure, dyspneic, walking up the stairs, orthopnea. Summary. Here are core messages. GLP-1 are proven secondary prevention agents in diabetes with established cardiovascular disease. This reduces MI and stroke. Robust trial data. Benefit go beyond blood sugar, weight loss, blood pressure reduction, better lipids, less inflammation, improved endothelial dysfunction, possibly direct cardiac benefits. Multifactorial benefit explain robust cardiovascular effect. Heart failure with preserved EF is clear indication. Heart failure with reduced EF requires caution. Heart failure with preserved EF plus obesity is strong move. Heart failure with reduced EF or recent decompensation, pump the brakes. Wait. Safety is good. Side effects manageable. GI effects commonly but transient. Serious complications rare. Safe in the medication class. Dehydration risk is real in specific population. Advanced CKD, diuretic use, concurrent SGLT2 inhibitors require vigilance. Monitor kidney function, constant hydration. Cause currently barrier but temporary. Genetic 26 to 27 drop price dramatically. Use manufacturer assistance program. Patient selection matters immensely. Not everyone needs one. Use clinical judgment. Field rapidly evolving, new drugs coming, new indication, new formulations, stay current. These are powerful tools that prevent disease when used appropriately. Prevent MI, stroke, improve heart failure, enable weight loss, improve metabolic health. Transformative medicine, not magic pill, work best combined with lifestyle changes, other meds, patients engagement, a tool, not the cure. Bottom line, patients with diabetes and heart disease or obesity and no contraindication, GLP-1 deserve serious consideration. Used throughout improve outcomes. Thank you.